Ladies and gentlemen, I'm very pleased to welcome you for my lecture from Warsaw, which is far away, in this quite difficult and strange time for everybody of us. And I hope that soon we will be able to meet one another face to face. I'm the chief of the very big department of fetal cardiology. I am pediatrician and pediatric and fetal cardiologist, so my knowledge about the fetal heart defects started from pediatric cardiology, and then I learned something about obstetrics and how to evaluate the fetus. So first of all, I would like to ask the question why the evaluation of the fetal heart and the fetal cardiovascular system is really important. Cardiac problems are the most common congenital defects, and the most diagnoses are made in low-risk pregnancies and in low-risk families, which is very important. We must answer the question if the abnormalities which we see on the screen is the structural or functional problem. As in such situation, we have to cooperate closely with obstetricians, and the decisions which are made concerning the further course of the pregnancy must be made together, and very possible is to avoid unnecessary premature delivery if it's not really necessary. It is important that treatment is possible of majority of congenital heart defects, and we must remember as well that benign cardiac defects, some quite commonly are the sign of very serious chromosomal aberrations, so we have to remember about this. Why I was asked to share with you my knowledge, as we are really the biggest fetal cardiac unit in Poland, one of the biggest in Europe. Every year we perform more than 3,000 fetal echocardiography, and about half of them are abnormalities, functional, structural, or arrhythmias, which is quite a lot. Additionally, the termination of pregnancy rate in Poland, even in the most difficult and serious heart defects like hypoplastic left heart syndrome, is very low, and it didn't exceed 10%. So we really have the possibility to observe the natural and unnatural history of congenital heart defects. Coming back to the fetal echocardiogram, what should we look for? First of all, we must know, of course, how many fetuses and what is the position of fetuses. We have to do the biometry of the fetus, and we have to evaluate the fetal-placental circulation, as the flow in the umbilical artery, middle cerebral artery, and the ductus venosus is very important for knowledge what is the condition of the fetal cardiovascular system. Then we are going to the abdominal cavity, chest cavity, and the mediastinum. We always start to put the transducer the down of the pregnant woman's abdomen, and then we are moving the transducer up. And then we are sure, like in this film, that the fetus is in the cephalic presentation, the spine is posteriorly, so it's easy to know what is left and what is right side of the fetus, which is the first part of the evaluation of the fetal cardiovascular system. Remember to know what is the orientation of your probe and where is the marker, because if you switch the probe, then you will mix left and right side, which is quite important. We start the evaluation of the cardiovascular system from the abdominal cavity, not from the heart. So we have to look where is the left hand side and right side, so we can see the stomach as the black hole, and it is on the left. Then we can see the aorta and vein. Vein is a bit anteriorly and on the right to the aorta. And of course, we can see the spleen, which is close to the stomach. This is the same plane as obstetricians measure the abdominal circumference, so everybody should remember what should be seen in this picture. So the checklist is that we have the umbilical vein, which is central in the abdominal cavity, the stomach is on the left side, the aorta is on the left side and posterior, the inferior vena cava, right side on the spine and anteriorly. and spleen is visible. So these are the checklist for the abdominal cavity, and this is normal. It should look like this in all healthy fetuses. Then we are using color Doppler, and we should see the first part of the communication between the placenta and the fetus, which means the ductus venosus. It is a very important vessel because this is the only way to deliver oxygen and everything to the fetus. So we really should be sure that the ductus venosus is draining into the inferior vena cava and that it is present, because if there is the absence of the ductus venosus, this is the important message for neonatologists, as they cannot catheterize the umbilical vessels, as they can ruin the hepatic vessels. So this is really important, and this is the only time during the entire life of the human being that this fetal placental circulation, portal and liver circulation is really seen. And we should see, of course, the portal vein, which is the first branch from the intrahepatic umbilical vein. So once more, from the abdominal cavity, we are going up to see the chest. As on the left-hand side, we see the stomach and the apex of the heart to the left side. And on the next one, we can see the apex to the left side and the vessels in the mediastinum, which looked normal as well. So now we are going to the fetal chest. We are checking the position of the heart. The heart is in the middle part of the chest, and its size should be about 1/3 of the chest cavity, and the angle, which should be about 45 degrees. Each higher angle, up to even 90 degrees, is the sign of the heart defects, in which the four-chamber view looks quite normal, like all conotruncal defects as tetralogy-of-Fallot, truncus arteriosus, and others. This is important that the heart is not on the left chest. It is in the middle. The two lungs should be seen properly, and they are almost equal in size. 2/3 of the heart is on the left side, so the whole left heart structures and the apex of the right ventricle. But the right atrium and the inlet part of the right ventricle is on the right side. It is very important because if the heart is moved to the left or to the right side, it means that something is abnormal. Most probably there is a defect in the lungs, additional, which is moving the heart. So the checklist of the cardiac position is like this, that the heart is 1/3 of the diameter of the chest. Both lungs are visible. There are 3 hearts in the chest cavity. The axis is 45 degrees. Apex is to the left, 2/3 on the left, 1/3 of the right side. When we know that the heart is in the normal position, now we are going to look at the main view, which is the four-chamber view. We must remember that the fetal heart is little, so it is important to enlarge image and to evaluate all structures of the heart in this bigger image. So we can see the normal four-chamber view, where both atria, which are down, are smaller. They are about 1/3 of the whole length of the heart, and they are equal in size, as well as the ventricle, which are equal in size. On the left-hand side, we see on this image the left ventricle. On the right-hand side, the right ventricle. We see the moderator band, which is in the apex of the right ventricle. This apex position of the fetal heart is the best of evaluation the anatomy, and we like when the fetus is lying like this, but of course we can change if it is in the other position. We can use different probe of scores, and the fetus can be in different positions. So here the fetus is completely different position because the left ventricle is on the right-hand side. So we must remember that it doesn't matter in which side it's lying, just the morphology is important. We can use different probes, and if we use the linear probe, we can see really many details. Like here, without any color, we see the pulmonary veins draining into the left atrium, and we see both ventricles and its anatomy, which is the left ventricle is ellipsoidal in shape, and the triangle, the right ventricle, the tricuspid valve, which is attached a bit closer to the apex than the mitral valve. And we can even see here that both mitral valve leaflets are attached into the free wall of the left ventricle, which is very important. What else we should see looking at the four-chamber view? The aorta must be on the left side of the spine, so this is important to look carefully what is behind the left atrium and in front of the spine. We must remember that in each cardiac cycle we have systole when the atrioventricular valve are closed and diastole when they are opened, and of course they are very nicely seen in the color Doppler. When we are using color Doppler, it is very important, and it's not possible to evaluate fetal cardiovascular system without this. We must adjust the color map according to our preferences, because there are few in each programs. We have to optimize velocity. It is very important because the velocity which is used in the obstetric programs are very low and the frame rate is completely different. So we really can't rely on this color. Each color you see when I am evaluating the fetal heart is the color which is adjusted for the velocities which are inside the heart, which means about 40-50 centimeters per second. And if I would like to evaluate the vessels, they must be a bit higher. If we evaluate the veins, it must be lower. So we must remember that we can't put the program for each part of the cardiovascular system. So we have to modify them during the entire examination. And power Doppler we can use when we would like to examine the lower velocities and mainly the venous flow. As you can see here, this is the normal classical color Doppler. So we see that there is the inflow through the both atrioventricular valves, the right one and the left one, and in the base position of the four-chamber view. And here the fetus is in the completely different position, so the apex is up. We can see both ventricles. We can see that the ventricular septum is intact. We can see both atria, and not very clearly, but we can already see the pulmonary veins which are draining into the left atrium, which is very important. In the cardiac cycle, we must remember that in diastole, both ventricles should be filled down to the apex of the left and right ventricle, and we can see it in the color Doppler. In systole, we can see in blue color the outflow to the aorta. We can't see the pulmonary artery in this projection. It's completely different projection. And in the systole, using not classic Doppler, but power Doppler, we can see the inflow into the atria and the outflow to the aorta. This is important to understand what's going on during the cardiac cycle. We must look carefully when we are using the color Doppler, as this is the first evaluation of the fetal heart function. And here, when we see inflow through the both atrioventricular valves, you can see the very, very little backflow in blue into the right and left atrium, which means that there is the insufficiency of the both atrioventricular valves. So we must think and ask ourselves the question why it is like this, as the tricuspid valve mild insufficiency can be normal. The mitral valve insufficiency is always abnormal in the fetus, so this is our first red flag that we must evaluate all part of the cardiovascular system very carefully. It can be the sign of arrhythmia, which at the moment they don't exist. It might be a sign in anemia or any other situation. So this is really very important sign. The other very important part of the cardiovascular system, these are pulmonary veins. Pulmonary veins really are very, very commonly omitted during our examination, which is bad. This very nice image of the 4 pulmonary veins, we call them the crab view, because we can see the 4 crab legs. But it is not so easy to see it in the fetus. So to this we used the new modalities. Here on the right-hand side you can see the left atrium and both pulmonary veins, lower and upper, which is draining from the one and the other side to this left atrium. So in this situation we are sure that the pulmonary veins are draining in the left atrium, so it will not be a problem in the neonate. When we are using just classical color Doppler, it is not so easy to see the pulmonary veins, and this is the reason that we have to use the other modalities. Like here in power Doppler on the left hand side we can see that the pulmonary veins are draining into the left atrium, but these new modalities, which is called the microflow imagings, are much better for evaluating the pulmonary veins because we can see them really very, very deep in the lungs. So this is much easier. And here we can see upper and lower pulmonary veins, which are draining really to the left atrium. So this is a very nice and very important image and very, very helpful in our everyday examination. Even if we don't have very good 2D image, using the MFI flow, we can quite easily evaluate the pulmonary vein drainage. We can use different modes of MFI. We have everything in black and white or grayscale. We can see here as well that the pulmonary veins are draining into the left atrium, and on the right-hand side we see the normal power Doppler of the normal pulmonary veins. Why am I talking such a lot about the pulmonary veins? Because it is still the Achilles heel in prenatal cardiac diagnosis. They are often forgotten that they are an important part of the cardiovascular system, and the drainage to the left atrium is not important for the fetus, so there is not an other sign that this drainage is abnormal. However, in the neonates, when the pulmonary flow is increasing just after delivery, the neonate's condition is deteriorating very, very quickly. So really our knowledge about the total anomalous pulmonary venous return is important for the neonatologist and for the saving life of the baby. As this is the defect in which the surgical treatment is the only option for save the neonatal life, because the prostin doesn't work in such a situation. So we should remember about the pulmonary veins. The four-chamber view can be seen from the apex, from the base, but from the lateral view as well. And here up is the left ventricle, down is the right ventricle, and on the right-hand side we can see very clearly both atria and the opening and closing of the AV valves and the drainage of the pulmonary veins once more. So when we are evaluating the four-chamber view, which is the most important view, the first view of evaluating the fetal heart, we must be sure that the apex is on the left side, that aorta is on the left side on the spine, that both atria, left and right, are equal in size, that the foramen ovale flap is in the left atrium, which means that we have the right to left shunt across the foramen ovale, which is normal for the fetus. We must see the pulmonary veins draining into the left atrium. We should know that the atria are 1/3 and the ventricles 2/3 of the entire length of the fetal heart. Both ventricles are equal in size, whereas the left ventricle is ellipse in shape and the right ventricle is triangle. And tricuspid valve is closer to the apex, because we must remember that in many congenital heart defects, it can be the ventricular inversion when the right atrium is connected to the left ventricle. So it doesn't mean that the left ventricle must be on the left side, but its morphology must be like in the left ventricle. So from the four-chamber view, we are going to the outflow tracts. And the first view is, which we call the five-chamber view, which means that we have two atria, two ventricles, which are down. We can see in blue two flows into the both equal-sized ventricles. And in red, from the left ventricle, we can see the aorta, which is squeezed between the atrioventricular valves. This is very important because they are connected, both rings of mitral and tricuspid valve and the ring of the aortic valve made the skeleton of the heart. And we should see the crossing over the great arteries. First one on the right side, we can see oblique going the pulmonary artery, and we can see the outflow from the pulmonary artery on the left-hand side. And from the left side, we can see a bit turbulent velocity, a bit higher velocity in the aorta, and I hope that everybody sees that both big arteries are crossing. The aorta is going from the behind anteriorly, and pulmonary artery is going anteriorly to posteriorly and cross to the aorta just after they are going out of the heart. This is the M mode of the child because it's much easier, but it showed us that there is the continuity between the ventricular septum and anterior aortic wall and the anterior mitral valve leaflet and the posterior aortic wall. So it showed us really that the aorta is squeezed between the tricuspid and mitral valve and is in the continuity with the mitral valve, which is very important to make the proper diagnosis of some difficult heart defects. From the lateral view, we can very nicely see the crossing over of the great vessels. Just below the sternum, we can see the pulmonary artery and the pulmonary valve, which is just below the sternum, and it's going posteriorly. And from the back, we see the aorta, which is draining then to the body. And in the down picture, we can see the nice mediastinal view, in which on the left side is the pulmonary artery, in the middle is the aorta, and the right side is superior vena cava. As I told, we should enlarge the image. So in this small image, we of course see the crossing of the great arteries, but here it's seen much, much better. So in the front is the pulmonary artery valve, and then the pulmonary trunk and is going behind the aorta, which is rising from the ventricle, which is more posteriorly. And in the picture, in the five-chamber view, we see the left ventricular outflow tract, and on the right-hand side, right ventricular outflow tract, like is seen in the arrows. And once more, we can see everything from inflow to outflow. So inflow, we see the pulmonary veins, which are going through the mitral valve to the left ventricle, and then we see the aorta rising from the posterior ventricle going up, and pulmonary artery from the anterior ventricle going down. So we can see it both in 2D image and on the MFI image. So we have to remember that aorta is in the middle, and it has to arise from the left ventricle. It should be mitral valve to aorta continuity. Pulmonary artery should be in the front going posteriorly, and both arteries should be equal in size in the third trimester. Pulmonary artery can be slightly bigger, but it shouldn't be smaller than the aorta. Flow should be laminar, and it's in the third trimester is up to 100 centimeters per second, and in the same fetus, pulmonary artery velocity should always be a bit lower than the aortic velocity. And now we are going to the mediastinum. This is a very important view because evaluation of the mediastinum by routine obstetric screening of the cardiovascular system made us understand a lot of vascular rings which were much easier to be seen in the fetal life than after birth. What is the mediastinum? So we are going just over the heart, and we should see the aorta, pulmonary artery, and the veins which are in the high mediastinum. We should see which is left and which is right side of the fetus, and we should see the number of vessels. They should be 3. We should see the position of the vessels, so aorta and pulmonary artery should be on the left side of the trachea, and superior vena cava should be on the right side of trachea. So we should see 3 vessels, not 2 vessels, not 1 vessel, but 3 vessels. We should see the size of the vessels. So in a normal fetus, aorta and pulmonary artery are almost equal. Aorta can be a bit smaller, and superior vena cava can be smaller than both vessels. It shouldn't be different. So if the superior vena cava is larger than aorta, then we must think why it is the situation like this. We must see the direction of flow. So pulmonary artery and aorta should be the same direction, and of course the vein should be the different direction. And we should look if if in front of the spine, between the spine and the trachea, if we see or not see any vessels. So from the lateral view, we see the aorta arising from the left and pulmonary artery from the right ventricle, and up we see the 3 vessels like on the right hand side, pulmonary artery on the left, aorta on the left, both vessels on the left side of the aorta, and superior vena cava on the right side of the trachea. What is important when we are looking at the mediastinum? We should see the thymus. The thymus is surrounding both vessels, and it's the reason that the vessels are in the middle of the mediastinum between the sternum and the spine, not very close to the sternum, as if they are very close to the sternum, it means that the thymus is hypoplastic or is absent, and it is a sign of the DiGeorge syndrome, which can coexist in many conotruncal defects. The thymus has the completely different echogeneity as the lungs, which we can see that the lungs are lighter than the thymus, which is surrounding the both vessels. So if we started to look at it, we will be sure that we see the thymus and that it really exists. Typical mediastinal view, 3-vessel trachea view in the a bit long axis that we can see in long axis on the left-hand side, pulmonary artery, and in the middle the aorta, and the small trachea, and in the front the superior vena cava, and 3-vessel view in which we don't see the trachea on the right-hand side. Of course, color Doppler or power Doppler is very, very helpful. Both arteries should be equal and in the same direction, and they should make the V sign, and this V sign is normal for the normal fetus. And as we can see on the right side of the trachea, we see in red the superior vena cava. On the right-hand side, we are going a bit down, so we see the pulmonary trunk, And then when we omit the ductal arteriosus, like here, we can see the both left and right pulmonary arteries, which are equal inside. The left is going to the left lung, the right one is surrounding the aorta and going to the right lung. So this is important because sometimes there is the absence of one pulmonary artery and they are rising from the different position. So the bifurcation is important to evaluate during the whole fetal heart examination, not in the screening, of course. And microflow imaging is very helpful, as we can see much more and many vessels, especially when we use the presentation when we can cut surrounding tissues and then we can see just entire vessels which are equal in size. This is very helpful, especially if the image, 2D image is not very good, so it can help to make the proper diagnosis. And the important, when we are evaluating the mediastinum, these are measurements, as this is the first abnormality which can be seen when we suspect the coarctation of the aorta, one of the most common congenital heart defects, which is very difficult to diagnose prenatally and potentially dangerous for the neonate. If we see both vessels like this, both arterial vessels equal in size, then it means that most probably the baby will be normal. We measure them just in front of the spine when they are meeting aorta, isthmus of the aorta and ductus arteriosus, and the measurements should be almost equal, or the ductus arteriosus can be a bit bigger. We have z-scores and normal values to which we should adjust this and compare if this is normal or abnormal, because it's important. If one vessel is bigger than the other, it's important in which part, and it's important if one vessel is smaller or the other one is enlarged, because the cause of this can be completely different. So those measurements are really important and, as you can see, are quite easy. One extra vessel which can be seen in the mediastinum, and sometimes we have referral that it is something abnormal. This is the vessel which is crossing both arteries and going anteriorly from the left to the right side, and this is the typical image of the brachiocephalic vein, which is draining all venous flow from the left part and draining it into the right-sided superior vena cava. So this is completely normal view, not abnormal. You can see this crossing perpendicular red vessel, which is draining blood from the left to the right side. So the checklist of the mediastinum, both arteries should be equal in size. Superior vena cava is on the right side. We should see 3 vessels, and they should be in the middle between the sternum and the spine. The thymus should be seen. And if we are doing measurements of the ductus arteriosus and isthmus, they should be just in front of the spine, not in the middle, because in the middle is pulmonary trunk, which is usually a bit wider than the aorta. Why it is so important to look at the mediastinum? Because we have some kinds of vascular rings. The most important is abnormal right subclavian artery, which can arise at the last vessel from the aortic arch, and then it's draining from the left side to the right side. But to cross from the left to right, it must go behind the trachea, so between the trachea and the spine, so it potentially can compress the trachea and the esophagus. And here you can see this vessel which is going up to the right side, and this is abnormal subclavian artery, which is called arteriosuria. This is the scheme, and this is a very nice MFI, and we can see very, very clearly the wide vessel, small vessel, which is draining into the right arm as the last vessel from the aortic arch. Microflow helps as well because it really we can really see very clearly the vessels. Here we can see really the this long vessel going into the right arm as the last vessel from the aortic arch, and here we can see very low arising of the abnormal subclavian artery. So this is important, and it's much easier seen in the fetus than after delivery. And then we are going to arches, as we used to say as cardiologists, that the human being have the aortic arch, but fetus has two arches. Our fetus have two arches, aortic arch and ductal arch, and both are equal in size. The arches should be evaluated in the sagittal view, and using the linear probe we can see it really quite early, like in 16 weeks of gestation. This is the aortic arch in 2D and in color with head vessels, so certainly this arch looked completely normal. And as we stop them in still images, we can see as a stick. This is the aortic arch with head vessels on the left-hand side, and like the hockey stick, the ductal arch without any head vessels. This ductal arch is very important because it is the main way from the right ventricle into the lower part of the body, as the right ventricle of the fetus works as the systemic ventricle for the lower part of the body, whereas the left ventricle works as the systemic ventricle for the head and the arms, so the upper part of the body. It is very important when we are evaluating the fetal cardiovascular system. New modalities when we evaluate the aortic arch is important, especially that I already told that the coarctation of the aorta, which is in the isthmus, and this is the part when the aorta is connecting with the arterial duct, is quite difficult to evaluate, especially that just 8% of the combined cardiac output is flowing through this aortic isthmus. So here we can be sure that this aortic isthmus is really normal, and as you can see in this mode is seen much better than in 2D, and then the size of the vessel sometimes is much easier to measure using these new modalities. As well, we can use, of course, other color here. We see in 2D as well, but I think that much better we can see in MFI flow the head and neck vessels, which can be evaluated. And in sagittal view, here we can see two arches. The aortic arch is more to the head, and here it is seen very nicely the ductal arch. A bit upper is the and in the front is the pulmonary valve, in the middle is the aortic valve. And the beautiful ductal arch, in this view we can't see properly the aortic arch, but we can see very, very clearly the aortic valve. And when we look carefully and have the proper image and proper probe, this one is the linear probe, we can even see the three leaflets of the aortic valve, which is quite important because the bicuspid aortic valve is the most common congenital heart defect among all others. So seeing the three leaflets of the aortic valve is quite important. Of course, it's not for the screening, but for cardiologists is quite important to see this. And the last part of the cardiovascular system are systemic veins. So in normal human being, in normal fetus, we should have the superior and inferior vena cava. On the left-hand side of the screen is the superior, and the inferior is down, and they should drain into the right atrium, which is very nicely seen. In cardiology, we like short axis very much, because here we can see the anatomy of the atrioventricular valves. Down is the anatomy of the mitral valve. We can see the two papillary muscles, and we can be sure that this valve is attached into the free wall, because the interventricular septum, which is a bit up, is completely free. So the mitral valve is not attached into the ventricular septum, and we can reconstruct it in 3D. So once more, down is the left ventricle, up is in the right ventricle, and on the right-hand side we can see the aorta, which is in the middle. This is the circle in the middle. And the pulmonary artery is down, and the right pulmonary artery is surrounding the aorta. So we can play with the rendering mode, learning how really the fetal heart looks like. Then we have to evaluate cardiac function, fetal cardiac function. And I always say that it is important to have the very simple methods, the methods which can be used for the everyday and which can be used quickly, because it can't be very sophisticated, as nobody can do this every day. So in my unit, we used, of course, M mode. So even we don't have to measure them, but we can see that both ventricles are contracting. So the contractility of left ventricle, which is up, and right ventricle is normal. But always we use the myocardial performance index, which is the Doppler index, which measures the inflow and outflow time, and isovolumetric and contraction and relaxation time. And for us, this is a very good method for everyday evaluation of the fetal heart. This is easy to evaluate is on the left side, because we can detect flow in the same image, inflow to the left ventricle through the mitral valve, which is down, and outflow to the aorta. And in this image, we can measure the atrioventricular conduction time, which is important when we evaluate fetuses of mothers with antibodies. And on the right side is more complicated, because we have to do it separately through the tricuspid valve and pulmonary artery. We must remember that the fetal heart rate should be equal in tricuspid valve and pulmonary artery to measure the real T index. So these are two modalities which we used in our everyday practice and in each fetuses, which is important. And we know that if the T index is higher than 0.5, then we must think why the situation is, and if it is really abnormal or we did something wrong during measurements. So, and the last part is the question if 3/4D mode for fetal heart evaluation is helpful. For the fetal heart evaluation, stick is the best. Real time is much more difficult and not so useful. This is the normal stick volume, which means that we can store about 1500 2D images. From that, first of all, we can reconstruct 4-chamber view and any other view in different rendering mode. On the left-hand side is the what we called true view, which means like this heart should look normally. On the right-hand side, this is the dynamic mode. So, but we can see the depth of this heart, that this is really the volume, not just the plane to the image. We can use different modalities. This is the reconstruction of the mediastinal mode, and everything can be made from the same stick. So we have one volume, and then we can play in different directions and different views. These two are normal, true view, and the other modes, it depends what the people like. And on the right-hand side, we have a very interesting image, which I called the ultrasonographic angiography, which means that we see the vessels, the inside of the vessels are filled, not the outside of the vessels. So the upper is the pulmonary artery, then is the aorta, so like the mediastinal view, and down is the inferior vena cava. So we can reconstruct and we can play and we can look from very different modes. And if we have really the good stick volume obtained, we can have the reconstruction of the entire cardiovascular system in one image. So we tried to obtain the best 4-chamber view. On the upper left-hand side, we can see the stomach on the left side, the apex on the left side, which we can see on the picture below. The 4-chamber view looked completely normal. We can distinguish between left and right ventricle. Then in the middle image, the third picture, we can see the 5-chamber view that the aorta is raising from the left ventricle. And in the down images, we can see the mediastinum view, even with the bifurcation of the pulmonary artery. So if we have perfect image, we can store this image, send to somebody and ask somebody, can you tell me if this heart is normal or abnormal? So it is important and it can be useful. So answering the questions if the new technologies in fetal echo are really important and help us. Certainly they enable to improve images and can help us in making the final diagnosis. It is possible to see much more details in fetal cardiovascular system anatomy, and I see how much we see now comparing to my first steps in fetal echocardiography, which was more than 20 years ago. Microflow images is excellent for evaluation of the vessels, and I am really impressed how much can we see in arterial system and venous system as well. Spatiotemporal image correlation can be helpful. However, it is not easy, and somebody who is doing this must have a knowledge about technical details, how to obtain the perfect volume, and for which this volume is necessary. We must remember that screening should be done in every obstetric scan, so each modalities which helped obstetrician to do the proper screening are helpful and useful. And we must remember that cardiologist consultation is obligatory in any suspicion of fetal cardiovascular system abnormalities. So, summarizing, this is the screening in low-risk pregnancy, which is of course much easier than the whole evaluation of the fetal heart scanning. And once more, the quick referral for fetal echocardiography is obligatory, as many cardiac defects are dynamic, and sometimes it is possible to introduce the fetal therapy early in pregnancy to change the natural history of the disease. Thank you.